Hey, you nurses out there who are taking care of pediatric patients on the floor or in the ER, or you might just be preparing for your NCLEX or other credentialing examination. Today we're going to talk about acute epiglottitis, and we're going to compare and contrast it with laryngotracheal bronchitis, more commonly called croup. And the first thing you need to know is that one of the problems is right here, and the other one is just a few centimeters away right here. But the other thing you need to know is that one of them sounds horrible but is mostly harmless, while the other one is quiet but deadly. I'm Dennis Stanley, and I'm a respiratory therapist, and I'm also a neonatal pediatric specialist. So today we're going to explore acute epiglottitis. All right, now as we dive into acute epiglottitis, remember we can't help but compare and contrast it to a degree to croup, sometimes called laryngotracheal bronchitis. Now, laryngotracheal bronchitis or croup is an entirely different problem altogether, and please watch my other video on that because it very much is different. However, both conditions result in an upper airway obstruction, which causes distress in the patient. And the obstruction is actually in a different place and it poses a different kind of threat. Today we're going to talk about upper airway obstruction that is related to acute epiglottitis. All right, so let's dive in. Now, when it comes to acute epiglottitis, keep in mind that it's about the location of the swelling. And the key here is all about the glottic opening or the glottis. So in this case, acute epiglottitis is going to occur as inflammation above the glottic opening or above the glottis. In that area, we mostly have soft tissues. If I were talking about croup, I'm going to tell you later, that's going to occur below the glottis. Below the glottis, of course, we have some rigid structures and some cartilage there. And so although there's inflammation, it's less. It has a tendency to collapse the airway just a little bit less. Sounds bad, but it's not nearly as dangerous as acute epiglottitis because when we have swelling of tissues above the glottis, there's not much rigid structure there or cartilage, and so the tissues can close completely. They can swell completely and completely close the airway. One of the key signs here is that you'll hear upper airway stridor, which is just really kind of a sonorous, interrupted sound. You've probably heard that before. And the thing about that is that because the airway can close completely up there in the soft tissues, then it can be deadly, and it can literally become deadly within just a few minutes. So we're very afraid when a child comes in with acute epiglottitis. The other thing is that underpinning acute epiglottitis is usually a bacterial infection. And so we'll talk about the inferences there, whereas croup is going to be more of a viral infection. Not always. Both can start with bacteria and both can start with virus. But generally speaking, you'll find that the patient with acute epiglottitis has a high temperature because they probably have a bacterial infection. All right, so let's take a look at some of the findings that you might see in a patient with acute epiglottitis. Now, one of the things that's happening is that the patient has swelling above the airway, or above the glottis, I should say, in the upper airway. And it's so much so that they're going to be restricted from breathing. They're on the very edge. Because of that, some of the things that you might see are really related to that. One of them is that you might see drooling. And this is because the child does not want, their body just kind of automatically knows not to try to take the time or the energy to swallow anything. You and I, and even them, when everything's normal, if we have secretions that come from our airway, or rather our mouth, the saliva, you and I are going to just simply swallow that from time to time. But for a child with acute epiglottitis, the body is going to react by not swallowing anything or even not engaging in the swallowing process. Consequently, mouth saliva and secretions can develop in the mouth, and then it wants to just come out of the mouth because the child is not swallowing. And this is going to cause a certain kind of drooling. The other thing is that upon examination, we'll talk about this because you do have to be careful with examination, but upon examination, you'll find that they have cherry red arytenoids, and so we'll talk about that, and we'll even show you that. Their mouth might be open because that's the natural response to respiratory distress, is to keep the mouth open all the time. And then you also might see other signs like that their eyes are wide open. And they're wide because they're having trouble breathing. The same thing would happen to you. If you are having difficulty breathing, the first thing that happens is your eyes get bigger and you open those up because you're having difficulty. All right, when it comes to radiological evidence, and this is the key method of diagnosing, we're going to get a neck x-ray and it's going to show supraglottic swelling. Remember, supra means above and above the glottis, whereas croup is going to be subglottic or below the glottis. The swelling is going to be there. And so the swelling is in the upper airway above the glottis, so it's going to be supraglottic swelling. And here's an example of a lateral neck x-ray that shows supraglottic swelling. Certainly you don't have to become a radiologist to know this, but we just want you to know how this is diagnosed. Look by looking at this lateral neck x-ray and seeing supraglottic swelling right there. All right, but this is probably a more telling picture. This is a good example of acute epiglottitis compared to a normal glottic opening and the surrounding area. If you look on the left, you'll see that there is a ridge there, that white ridge that surrounds the glottic opening, and of course that's going to be just normal. But look what happens when it starts to swell. If you look on the right, you can see that there's much swelling. Now this patient has an endotracheal tube in, and if they didn't though, can you imagine those tissues? Those tissues could swell completely over the opening, and that would present the deadly problem at that case. One of the key treatments that we'll talk about later is that you're going to want to establish an airway, because of that tissue can go right over the airway within just a few minutes, and then that can cause severe respiratory distress, but also could pose a terminal problem. So it could cause death. And so that's why we care about acute epiglottitis. Now let's take a closer look at comparing the two and some of the key attributes, because they really are very different, even though they both can cause distress in the patient. So again, we're not going to become an expert of croup here, but we can't help but look at croup just so we can compare and contrast acute epiglottitis. So what you'll see is that croup has a tendency to be more viral in origin. And because it's viral in origin, we don't typically see extreme temperatures or hyperthermia in that case. So we might have a low-grade fever, might even be afebrile. And remember, we said the swelling is going to be subglottic or below the glottis. And then the person with croup will have a barky cough, but it sounds horrible if you've ever heard it. They sound like a seal that's coughing, and we'll cover that in the croup section in the croup video. Please watch that. But it's not life-threatening, even though it sounds horrible. And so I know there's been nights where my own child will make a croupy sound, and my wife will wake me up because it just sounds horrible. Sounds like your kid's about to die. And I woke up one time and listened to it, and it sounded croupy like this, and I said, oh, it's okay. You can probably just go back to sleep. Of course, I got in trouble for that. But anyway, what I was really trying to say was I was just trying to figure out if it's croup, then it's not acute epiglottitis. Acute epiglottitis is the deadly one. That's the one you care about. Well, let's take a look at that. Instead of a viral infection, then acute epiglottitis is going to have a tendency to be bacterial in origin. And because it's bacterial in origin, it's not uncommon for the child to have a very high fever as a result. And then, of course, we get the x-ray, and we're going to find out that there's supraglottic swelling. Now, remember we said it's kind of an emergent situation for the patient in terms of breathing, so they're not going to want to swallow, but they're also not going to want to cough. Whereas in croup, they're going to be coughing. It's an irritant. It's going to sound like a kind of a barky seal. But in acute epiglottitis, typically the patient's not coughing at all because the body has entered that emergency response. All right, so let's take a look at the stridor. Both croup and acute epiglottitis can demonstrate stridor, but what we're going to see in terms of treatment is in acute epiglottitis, if the stridor is considered mild or moderate, then we might have just a little bit of time to treat the patient. Now, I want to dispel a myth here that we see. With acute epiglottitis, we see sometimes home remedies of giving like cool air or cool mist. In fact, we sometimes tell parents that if you think that that's what's happening and it's cold outside, put them in a cold environment so they can breathe cool air. We're trying to decrease the inflammation. But in the hospital or in the healthcare setting, we don't really like to use cool mist for acute epiglottitis just because it's not effective enough. What we can try, maybe for just a little bit, is a drug called racemic epinephrine. And I'll talk about that, but it's a vasoconstrictor, so it's an alpha-1 constrictor, so it can decrease the inflammation sometimes very quickly. However, if we start looking at stridor and the stridor is really marked or severe, then we're not going to have time to try racemic epinephrine. We're going to have to go ahead and establish an airway. And you're going to intubate, and we'll talk about that in just a minute. We're going to intubate probably very carefully with a video assist device. We can't just get a laryngoscope and go down there and start poking the tissues. We need to see exactly where we're going. In fact, it's very common to take a bronchoscope, if you know what that is, and put an ET tube on the bronchoscope and then go down with the camera in the bronchoscope and then very carefully see the hole. And it might be very, very small. And once we get through that hole, then we advance the tube, and that's how we establish an airway. But it's also not uncommon to send that patient directly to a surgical situation or a place where they can be sterile. And the reason why is because the surgeon or the anesthesiologist or whoever you have might be trying to intubate with a laryngoscope or a video assist device in this hand, but they might have a scalpel in this one. Why? So if this doesn't work, they can just do a trach. They can put in a trach. And so sometimes children with acute epiglottitis will need a tracheostomy. But it's really all about establishing the airway. Now let me talk about racemic epinephrine. If the stridor is simply mild, it's kind of early on, you could try to deliver an aerosolized or a nebulized version of racemic epinephrine. It's just kind of like an albuterol treatment that they breathe in for wheezing, only this time they're going to be breathing it in to decrease the inflammation in the upper airways. But there's a couple things you don't know, and a lot of ERs and a lot of ER physicians might not always know this. And that is that, yes, racemic epinephrine can work within just a few minutes to decrease swelling. The problem is that it has a tremendous rebound effect. And so what that means is that it'll decrease swelling, but it could be that 60 minutes, an hour, 4 hours later, the swelling comes back and it's even worse than the first time. That's what the rebound effect is really all about. Because of that, even though it looks good, you've reduced the swelling, you think you've avoided intubation, and you can send the patient home, what most protocols should include is keeping the patient and monitoring them. Technically, you want to monitor from 2 to 24 hours. In my opinion, always at least about 6 hours. What also happens is that for some strange reason, acute epiglottitis has a tendency to rear its ugly head at about 7 p.m. at night. I don't know why, but it happens at night. And that means by the time that the parents get to the ER and the patient gets looked at, it very quickly is becoming like midnight. So it's very common not to send the patient home with the parents at that point, but sometimes just keep them overnight. And so watch them for 6 hours, 12 hours, and then maybe the next morning, if it looks good, then they can be discharged. But that's the thing with racemic epinephrine. It has a rebound effect, so you want to generally keep the patient and monitor them. It's not always a good idea to send them home, even though they look like they're doing pretty good. When it comes to establishing an airway, we talked about this, just remember that you need to use an intubation assist device, particularly a video assist device, because when the endotracheal tube is being advanced through there, you want to make sure that you can see it. One common way to do that, there's lots of video assist devices that can do this, but a bronchoscope is one of those that has a camera, and you can put the tube on the bronchoscope and then advance it in there. But there are other little simple video assist devices. What you don't want to do is what we call blind laryngoscopy. And that's when we just take a laryngoscope and we start poking it down there, trying to lift anatomy so that we can put a tube in there. And the reason why we won't want to do that is because just touching the tissue can elicit an immediate and a complete inflammatory response that can close the airway literally within just a few seconds. So we don't want to be poking things in there, and I'll talk about that more in just a minute. But as I said, a tracheostomy is also an option. Now, I said you want to avoid direct laryngoscopy, but in fact, you want to be very careful with putting anything in the child's mouth. In fact, we say don't do that. Hopefully, and most of the time, you can just have the child open their mouth and you can look in, and you'll see the cherry red color of all of the problems back there, and you'll understand, you'll see the swelling very often. But what you do want to be careful of is that sometimes the tongue is in the way. So in this picture, they're actually doing something that is permissible. Notice the tongue depressor is being used as exactly that, but it's very forward on the tongue. It barely penetrates the plane of the teeth because we don't want to go back in that area and accidentally touch anything with our tongue depressor or anything. But in this case, you might need to use the tongue depressor literally to just push the tongue down so that you can visualize the anatomy. In most cases, just asking the child to open their mouth, and by the way, it's probably already open because they're having trouble breathing. You can just look in there with a flashlight, little pen light, and you'll see the swelling, and that's good enough. Then combined with things like drooling and distress and wide open eyes, that's how you know that you're dealing with a case of acute epiglottitis. Now, when it comes to treatment, certainly we want to make sure they can breathe well, establish an airway, make sure we protect the airway and prevent it from sudden closure. Closure and inflammation can occur within a few minutes, and one might say even within a few seconds sometimes. It can change within 30 seconds, it can close all the way up. So the key here is going to be establish an airway, but then the backup plan, or the thing that you need in adjunct with that, is to be able to address the infection. Remember, it's usually accompanied by a bacterial infection, so antimicrobial antibiotic therapy is going to be key here. To some degree, you could also use anti-inflammatory medications such as corticosteroids. That's often used. It's questionable as to how well it helps in the moment. And then, of course, you could also do culture and sensitivity once you've got the patient stable, so you know the organism that's causing the problem, the specific bacteria, and that may help you to change your antibiotic therapy. Remember that you're going to start antibiotic therapy right off the bat. You're probably going to use something broad spectrum, but then once you get the culture and the sensitivity back, which is the identification of the organism that's causing the pathology, but also the best antibiotic to kill that pathology, then of course you can switch to that antibiotic therapy. So here's some key things to take away as you look at that. You're going to have supraglottic swelling. And on the x-ray, I didn't mention this, they may use the informal term, the thumb sign. That would be diagnostic for acute epiglottitis. It is supra or above the glottic information. It can be life-threatening. It's going to be quiet because the patient's not going to even want to cry. They're not going to want to cough. So it looks like they're okay, but you can see they're in distress. In fact, they're in emergent distress. And that's when the body says, we're not going to cry, we're not going to cough, we're not going to even swallow. And that's why you'll see acute epiglottitis has associated with those things. And of course, the key thing is to make sure and protect the airway. And then you can address the source of the infection, which is likely going to be through antibiotic or generalized antimicrobial therapy, whatever that is. And so that's a good survey of acute epiglottitis. Again, remember, we've compared and contrasted that with croup. But remember to look at the other video on croup so you can see the details there and you can get a good understanding of both conditions. I'm Dennis Stanley with Respiratory Sensei, and this has been a video for you respiratory therapists and even you nurses who want to know more about acute epiglottitis. If you've liked this video and you want to hear more from that perspective, be sure to subscribe and also hit the notify bell. Also, give me a thumbs up if we're on the right track, or if you have any questions, we'll be happy to try to answer those things. All right, this is Dennis signing off. We'll see you next time.